Hello, everyone. Welcome to Stanford Care's monthly community health talk series. My name is Kevin Chen, and I'm a medical student that will be moderating this talk today. I am pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Hill Library, and the Vincent V.C. Wu Memorial Foundation. Today's talk will focus on allergic diseases in the Asian American population. Allergic diseases are increasingly prevalent in the United States and now affect nearly 1 in 4 children. While the Asian American population is rapidly growing, little has been previously known about allergic diseases in the heterogeneous Asian American population. Our recently published work has shown a high prevalence of allergic diseases in certain Asian American populations. In this session, we will discuss the latest research finding on allergic diseases among different Asian American ethnic groups and the impact of allergic diseases in these communities. Now I'm honored to welcome our guest, Dr. Anna Chen Arroyo. Dr. Anna Chen Arroyo is currently a clinical associate professor and section chief of Allergy, Asthma, and Immunodeficiency in Division of Pulmonary, Allergy, and Critical Care Medicine in the Department of Medicine at Stanford University School of Medicine. Dr. Arroyo completed her undergraduate and medical degree at Stanford and received a master's degree in public health at UC Berkeley. After finishing her internal medicine residency at Stanford, she went on to complete a fellowship in allergy and immunology at Brigham's and Women's Hospital before returning to join the Stanford faculty. Her research had focused on understanding early life risk factors that influence the development of allergic diseases and the epidemiology of allergic diseases, with a focus on the Asian American population. She has been awarded multiple grants, including the Stanford Department of Medicine Chair Diversity Investigator Research Award, and has published numerous peer-reviewed original articles in leading national allergy and asthma journals. Now, without further ado, Dr. Oil, please take it away.
Thank you so much, Kevin. It's great to be here, and I'm very excited to talk to you all today about allergic diseases in the Asian American population. We've been studying this growing issue in our community in the last few years, and it's a topic that's very important to me. So I'm excited to be with you today to share a little bit more about the work that we've done. So just a little bit about the Asian American population, in case you don't have that much of a background. There are approximately 24 million Asian individuals living in the United States. Here is a map. The one on the left shows the share of the population in each county in 1990. And then the other map on the other side shows the increase in the share of the Asian population in each county by year 2020. If you can see here on the left-hand map in the 1990s, most of the Asian individuals are, in the coastal regions as well as near major cities, like here's the Bay Area, Los Angeles, Washington, D.C., and New York. And then over time, we see that Asian individuals have kind of spread across the United States in different geographic locations now, in the southern part and also in the Midwest as well. And the darker areas show a higher percentage of Asian individuals living in that county. And so you can see here that there's more darker regions as well. In addition to the Asian population spreading across the US in different geographic regions, the Asian population's also been noted to increase rapidly in the last few years, and then also is projected to double in size by year 2060. So it's going to be nearly 50 million Asian individuals living in the US by year 2060, which is a really rapid growth. And then if you look at the state of California, and this is just a kind of schematic, looking at the different counties in California, you can see here the spread of Asian ethnic groups across California, and that changes over time. So in the 1980s, there were less Asian ethnic groups in California, primarily Chinese represented in the red, Filipino in the aqua, green the Japanese, and also blue representing the Indian population. However, as time has progressed, now there's a lot more Asian ethnic groups across California, including the Hmong population in Northern California, as well as increasing Vietnamese population here in Southern California. And so the Asian American population is a very heterogeneous population. There's lots of different ethnic groups. And what I'm going to talk to you a little bit about today is first, how common are allergic diseases among Asian Americans? And secondly, I'm going to talk a little bit more about risk factors. Why are allergic diseases occurring in the Asian American population, or even more frequently in the Asian American population? And then lastly, I'm going to touch a little bit upon the clinical management of allergic diseases and treatment, and whether or not there are ethnic variations in clinical presentation of allergic diseases, and whether or not cultural considerations matter or impact care. So first, when most people think of allergies, they think about, hay fever, seasonal allergies, the common symptoms, itchy nose, watery eyes, nasal congestion, runny nose, maybe some symptoms that you are feeling and experiencing right now as we speak. And so even though this is the most common allergic diseases, there are other allergic diseases that can manifest in many different ways and affecting various parts of the body. These include skin conditions like eczema or atopic dermatitis, which is a chronic itchy skin inflammation manifesting in rashes, typically behind the knees and the elbow creases, that can last for days. There's food allergy, which is essentially immune system overreaction to specific food proteins. And allergic rhinitis, which is commonly known as hay fever, which is inflammation of the nasal passages triggered by allergens. And then there's asthma, which is chronic inflammation of the lungs that can also be triggered by environmental allergens. And so when we look at common allergic diseases among the population, it's very common. Nearly 1 in 3 adults reports having an allergic condition based on national survey data from recently from 2020. And so what you can see here is this is the percentage of adults reporting these specific allergic conditions, with the general population in the darker color and the white population in the maroon color, and then the non-Hispanic Asian population in the bright red color. And then when you see here is, the reported eczema prevalence. It's similar, among non-Hispanic Asian groups when you combine all the Asian ethnic groups here, when you compare that to the general population. Food allergy may be a little bit, the Asian adult population reports a little bit less than the general population. Seasonal allergy and asthma, the Asian adult population does report a little bit less frequently these allergic conditions compared to the general population. And then in kids, allergies are also very common. More than 1 in 4 kids report having, or the parents report having an allergic condition. Similarly, when you look at these different groups, Asians, when grouped all together, maybe has similar reported eczema prevalence, a little bit higher reported food allergy prevalence, and then lower seasonal allergy and also asthma is reported among Asian kids as opposed to the general population or the white population. But the question is, these are all data that's survey reported, so people reporting these allergic conditions. And also, they're not looking at specific Asian ethnic groups. And so some of the more recent data has looked at, breaking down this Asian group into different ethnic groups and looking at whether or not allergic diseases differ in these different ethnic groups. And what you can see here is this is some survey data from 2019, also from nationally represented data. And what you can see is they looked at Asian Indian population represented in the blue, the Chinese population in the orange, and the Filipino population in the yellow. And they found that compared to non-Asian kids, Filipino kids had higher reported, were more likely to report food allergy here in the left, eczema in the middle, and also asthma here that we can see. They were not able to break down the other Asian group due to sample size, but the other Asian groups seem to also have reported higher the risk of food allergy as well as eczema. So it's really important to understand, that the Asian American population is not a monolith, and that there are various different ethnic groups that are represented in the Asian American population. For instance, in the US, the most common Asian ethnic groups are the Chinese, so about 20% of the Asian population, Asian Indian population around 19%, the Filipino population around 70%, Japanese around 6%, Korean around 8%, and Vietnamese around 9%. And so when we talk about research in the Asian American population, it's important to split out these Asian ethnic groups because certain ethnic groups may have a higher risk of allergic diseases or higher prevalence of allergic diseases. And it's important for research and also clinical implications because we can develop targeted interventions and treatments for these populations. So um, what we did is, in collaboration with some of my colleagues at Sutter Health, we looked at kids, about 485,000 kids in the Sutter Health population, essentially kids who go visit doctors in Northern California. And of the 485,000 kids, about nearly a quarter were Asian American or self-identified as that. And then approximately a fifth or nearly 20% reported or did not had an allergy. So what we did in this study is we looked at electronic health record data. We looked at the charts and we looked at these specific allergic conditions using the electronic health data as opposed to asking parents or kids whether or not they had these allergic conditions. And we were able to look at other ethnic groups besides the ones that were previously noted, including Asian Indian, the Chinese population, multi-ethnic Asian, which we defined as having one parent of one specific Asian ethnic group and a second parent of a different Asian ethnic group or a different racial group, Filipino children, Korean, Vietnamese, and Japanese children as well. And what we found was that, the prevalence of allergic diseases differed across different Asian ethnic groups. We found that Filipino and Vietnamese children had the highest prevalence of these four allergic conditions. We looked at atopic dermatitis or eczema, food allergy, allergic rhinitis, and asthma. And you could see that the prevalence among the Filipino population was a little bit higher than the general population, as well as for the Vietnamese population. And when you looked at other allergic diseases like food allergy and allergic rhinitis among the Asian Indian children, we found a little bit lower prevalence of these allergic conditions among Asian Indian children. And then for Chinese and Korean children, we also noted that they had lower prevalence of asthma compared to the general population and the white population. And then besides looking at prevalence, we also looked at whether or not there was increased risk of these allergic diseases among these different Asian ethnic groups. And we found that Filipino, Vietnamese, and multi-ethnic Asian American children had a higher risk of multiple allergic diseases. For instance, Filipino children were twice as likely as white children to develop allergic rhinitis and asthma, 4 times as likely to develop eczema, and then 5 times as likely to develop food allergies. Then when we looked at asthma, there was a lot of variation between the different Asian ethnic groups. For instance, Filipino and Native Hawaiian Pacific Islander children had a higher risk of asthma as opposed to Chinese, Korean, and Japanese American children, which we found them to have a lower risk of asthma. And this was surprising to us because sometimes in kids, certain allergic conditions kind of go together. And so these populations had like for instance, the Chinese population had a higher risk of eczema and food allergy, but a lower risk of asthma. Then we looked a little bit more at this variation of asthma prevalence using some state data from the California Health Interview Survey. There was about 35,000 kids that were included in this survey, and they asked these parents and kids essentially if they were ever diagnosed with asthma. And we were able to control for body weight or body mass index, and we found that Filipino American children had the highest prevalence among the Asian ethnic groups, again with asthma, and they had increased odds of asthma as compared to white children. Similarly, we found that Korean American children had the lowest prevalence of asthma, as well as decreased odds or lower odds of asthma compared to white kids. Then we were interested in looking at whether or not this pattern actually was consistent across different age groups. And so using Kaiser data, along with some colleagues at Kaiser, we found that Filipino children, especially Filipino male children, had higher asthma prevalence across all the age groups. And you can see that Filipino children are in this bluish purple line here, compared to the non-Hispanic white children in this dotted black line on the bottom here. Similarly, for female children, Filipino children also had a higher asthma prevalence across all the age groups in early childhood, pre-adolescence, and adolescence compared to white children as well. If you can see here, for South Asian children, actually, South Asian male children had a higher asthma prevalence compared to white children across the age groups. However, this was not the case for female children. If you can see the green line representing South Asian children, that was similar to the dotted black line here. So South Asian female children had a similar asthma prevalence compared to white kids. Then when we also adjusted these numbers for obesity or body mass index, we found a similar pattern across the different age groups. Again, Filipino children had a higher asthma prevalence across the different age groups in this bluish purple dot here to the far right. So then we were interested not only looking at asthma prevalence or whether or not these kids had asthma, but also new asthma cases among young children and whether or not Asian kids were diagnosed more with asthma. And so we're looking at the asthma incidence here using Kaiser data. And when we group all the Asians together, you can see here that the asthma incidence is similar to the asthma incidence among white kids. And so you can see the blue column is very similar in height to the white column. Then when we break down the Asian group in different Asian ethnic groups, we find there is a variation again. So here's the red line represents the asthma incidence among white kids. So Vietnamese, South Asian, Native Hawaiian, Pacific Islander, and Filipino children have a higher asthma incidence compared to white kids, whereas Chinese, Japanese, Southeast Asian, and Korean kids were noted to have a lower asthma incidence compared to white kids among young children. So, we've talked a little bit about how common allergic diseases are among Asian Americans, but what about risk factors? Why are allergic diseases occurring more frequently in the Asian population? Well, while we're not certain exactly why, there are certain risk factors that have been studied and looked at, especially in the Asian population. So one, of these factors are genetic factors, which are unique genetic variations or polymorphisms affecting the immune response that could be affecting allergic disease development. Secondly, it could be migration effects. So essentially exposure to new environments and Western lifestyle um, could be affecting allergic disease development as well. And lastly, environmental factors, for instance, diet, pollution, and rural and urban environmental exposures. So in terms of genetic variations, the most well-established genetic risk factor that have been studied is looking at the genetic risk factors for atopic dermatitis or eczema. The most common genetic risk factor for atopic dermatitis are mutations in the gene encoding skin barrier function proteins such as filaggrin, which binds keratin fibers and skin cells and helps retain water in the outer skin layers and provides a defense against pathogens and allergens. Up to 27% of Asian patients with atopic dermatitis have this specific loss of function mutation for filaggrin, while for European atopic dermatitis patients is about 50% of cases. In addition, the specific filaggrin gene mutations are different for white population as they are for Asian population, and they're unique sometimes to each Asian ethnic group. For instance, there's been unique filaggrin mutations noted for Korean, Japanese, and Chinese populations. Then other genes that have also been implicated in Asians with atopic dermatitis include a gene that's been associated with atopic dermatitis in East Asians called SPINK5, or the serine protease inhibitor causal type 5. It's a gene that helps make a protein that helps the sturdiness of the stratum corneum, and helps to provide a barrier between the body and the environment. And then lastly, there's been some genetic variations or polymorphisms that have looked at specific cytokines in the allergic pathway, for instance, IL-4 and IL-13, and looked at how these specific genetic polymorphisms may be associated with atopic dermatitis onset. So besides genetic variations, migration has also been studied, especially in Asian populations moving to Australia, to the UK, to Canada, and also to the United States. And, from these studies, these limited studies, there seems to be a protective effect that happens when individuals move from a low allergy or country to a high allergy country, or where allergy is more prevalent in those countries. Also, the duration seems to matter as well. And essentially, the longer that you stay in your host country, that you have an increased risk of developing an allergy while in that host country, usually on the order of 10 years or so. Additionally, there's generational differences that have been noted. For instance, the first generation or immigrant population has a lower allergy prevalence than their children or second generation children. So children that are born from East Asian parents that were born in Asia have a higher likelihood or higher risk of allergic diseases, especially food allergy, compared to their parents. And then there is some suggestion about parental influence. For instance, some studies have noted that if a child has two foreign-born parents, as opposed to one foreign-born parent, kids have a lower risk if both of their parents are foreign-born compared to only having one foreign-born parent. So there's a lot of interesting work that's been looking at migration. As I mentioned, both in Australia as well as UK, Canada, and US, and more work needs to be done in this arena. So there's also environmental factors that have been studied, looking at allergic disease development. Some of that is looking at early life influences. For instance, the mode of delivery has been studied. There is a higher risk of allergic disease development in kids who are born via C-section as opposed to born via vaginal delivery. There's been some suggestion that perinatal antibiotic use or even maternal antibiotic use may be associated with higher allergic disease risk. And then also there's dietary changes that have been noted. Perhaps there's a shift from traditional to Western diet that impacts gut microbiome and immune development. And some of the studies have looked at polyunsaturated fatty acids, specifically looking at omega-3 polyunsaturated fatty acids as opposed to omega-6 polyunsaturated fatty acids, and looking at the ratio of this, whether or not this affects allergic disease development. And then also there's different allergens and pollutants that may affect allergen sensitization. For instance, there are some studies that have looked at kids that grow up in rural farming communities, and that may be a protective factor in developing allergic diseases. So lastly, I'm going to talk a little bit about clinical management and treatment, whether or not there's ethnic variation in clinical presentation, and whether or not cultural considerations impact care. So in terms of clinical presentations, there are noted food allergy trigger differences in Asia as opposed to in westernized countries. So shellfish is more common in Asian countries. About 5% of Asian children seem to have shellfish allergy versus less than 1% of these kids in the US. Similarly, peanut allergy seems to be more common in westernized countries. About 1% of prevalence has been noted in Asia as opposed to 3% in westernized countries. And wheat allergy has been also noted to vary, with it rarely occurring in Asian countries except Japan and Korea as well. There's been a study recently looking at food allergy triggers among Asian Indian children in the US. And they did a survey data and found that tree nut allergy was very common among Asian Indian children. And also that legumes were pretty common, such as chickpeas and lentils, about 11% were reported. So there's a lot of food allergy triggers that may differ across different Asian populations, Asian ethnic populations living in the US. In terms of treatment for allergies, the mainstays of treatment include, avoidance strategies, essentially identifying and eliminating specific triggers when possible, medications to treat symptoms, for instance, oral antihistamines, nasal steroid sprays or nasal antihistamine sprays, epinephrine, either nasal epinephrine or injectable epinephrine that will treat severe allergic reactions, asthma inhalers, and biologics or targeted therapies that treat severe allergic diseases such as eczema and asthma. Then there's also immunotherapy, which is essentially either oral food immunotherapy or allergen immunotherapy like allergy shots, which essentially induces immune tolerance over time through carefully administered escalating doses. And then, in terms of education, having culturally appropriate self-management strategies and emergency action plans are also necessary for management. So in terms of cultural considerations for care, in certain Asian populations, family dynamics is very important, and also the role of the family in decision-making as opposed to individual decision-making, and factoring that in is important in the healthcare setting. Food also is very important in a lot of Asian cultures, and so the cultural significance of traditional foods when managing food allergies is important to remember and to also manage as well. Holiday food traditions can sometimes be difficult for certain kids who have food allergies. And then trust building and cultural competence is important to establish a good therapeutic relationship between healthcare providers and patients in order to develop a good management and treatment plan that's suitable for the patient. And then language barriers are also an important consideration in terms of proper translation of services and also materials in patients' native languages. So again, I mentioned about food allergy triggers being different, but food allergy management techniques may also be important for Asian populations, not only because food is important, but common Asian foods contain major allergens such as soy, shellfish, fish sauce, and nuts appear in many traditional dishes. So finding culturally appropriate substitutions is also critical, and preserving important food traditions is important while ensuring safety for these patients. So I talked a little bit about the prevalence of allergic conditions or allergies among Asian Americans. And one big point is that seems to be that atopic dermatitis and eczema and food allergy are becoming more common among Asian American children. Why that is unclear at this point, but there are certain risk factors that have been studied among Asian populations, especially migration, and possible diet changes may contribute to allergic disease development. And then in terms of clinical management and treatment, there are differences in clinical presentation, especially for food allergy, and cultural factors may impact allergy care. Additionally, we touched on understanding that there's a lot of heterogeneity among the Asian American population, that the Asian American population is growing rapidly, and there's more than 20 ethnic groups that are represented in this group. And so it's important to kind of split out or disaggregate the data so that we can understand the risk factors and allergy profiles for these different Asian ethnic groups. Again, talked a little bit about migration effects, but studying immigration and generational status of these different Asian American populations may be helpful to understand the different allergy risk. And then also developing culturally competent materials and also other linguistically compatible materials is important. And it's important to address this for different Asian ethnic groups. And then in terms of research, again, our next steps are looking at more disaggregated data and developing targeted interventions for different Asian ethnic groups. So I'm at time. I just want to thank the Stanford Center for Asian Health Research and Education for giving me the opportunity to talk about this really important topic, and also all my collaborators at Stanford, Harvard, Kaiser, and Sutter Health, as well as the funding sources. Here are some of my references, and now I think we are going to questions.
All right. Thank you so much, Dr. Arroyo, for a very informative and great presentation. Yes, we have many, many questions, so I'll try to get through as many as I can. So one question that someone had is, are there any correlations between having food allergies and medication allergies in the Asian population?
Now, that's a great question. I think that there's really not that many studies looking at medication allergies among the Asian American population. I think more work needs to be done on that. Um, and I do, I think as we learn more about allergies among the Asian American population, we may find these differences as well among Asian ethnic groups. I think allergies in general, as I mentioned earlier, can manifest differently, and different individuals and different parts of organ systems can be affected. So it's possible that they are related, but we don't know that.
And then another question is, what is your current and future work and research kind of in the Asian American allergy space, and kind of where do you think the field is moving towards in the future?
Yeah, that's a great question as well. Currently, we're looking, as I mentioned, some of the data, but we're looking at what is the allergy risk profile of different Asian ethnic groups. And now that we find that there are certain higher risk groups, for instance, the Filipino population, the Vietnamese population, we're going to focus on why there is a higher risk in these specific populations. Is it diet? Is it migration? Is it other factors that we're not clear on? So that's kind of the next step. We're also going to look at other allergic diseases, for instance, as someone mentioned, looking at drug allergies, other types of allergies, not just the four common allergies that I mentioned. And then, sorry, there was a second question,
Yeah, just
Kevin.
where do you think the field is moving towards in the future?
Yeah, well, I hope the field is moving towards understanding these different allergic disease profiles, and then also understanding how these allergic diseases kind of change over time and over the life course. Most of my work, has been focused on kids, but I think as there are, some data looking at adults, and I think understanding how these different allergies manifest across the life stage, across different Asian asthma groups would be important.
Okay, and then someone had wanted to clarify when you kind of talked about low and high allergy countries, what does that mean? And also, like, what are examples of low and high allergy countries?
Yeah, so that's a great question as well. I think what I was mentioning is that if you are an individual that comes from a place that has a low allergy prevalence, for instance, peanut allergy is very low in your specific, Asian country, then you migrate to somewhere where there's a higher prevalence of, let's say peanut allergy or food allergy. Then over time, there is an increased risk, especially in the subsequent generations of developing that allergy.
Okay, and then when you kind of talked about comparing like Asian American populations to, individuals from their native country, like their parents, um, do you have any like studies on that on your slides or anywhere that someone can refer to?
Yeah, I think this video will be posted. So in the references, I mentioned some of the studies. Most of the studies
Excellent.
looking at that comes actually from Australia, from the HealthNet study, which is like a great population-based kind of study cohort that they followed over time. Most of their participants are of East Asian descent, if they are of a specific Asian ethnic group. And so that's some of the studies that are coming out that I mentioned here.
Great. And in general, are there any socioeconomic correlations for allergies and like, prevalence of allergies specific to asthma, but also in general?
Yeah, so and that's a great question as well. We've uh, also we've looked at certain socioeconomic factors, primarily income level, which is not, which is a proxy, but it's a an indicator of different socioeconomic status. We've also had a more recent paper looking at socioeconomic status indicators, whether or not this is correlated with allergic disease reporting. I think that there are a lot of different complex interactions between socioeconomic status and also different allergic disease profiles, but I think more work needs to be done in that arena. So that's a great question.
Yeah. And the next question is generally how effective is immunotherapy for children? Like for example, allergy shots. Generally how many years do people need on it? What are the benefits and are there cases where it can actually make allergies even worse?
Yeah, so allergy shots has been studied and been one of the mainstays of allergy treatment over time. Um, as I mentioned, it's giving escalating doses of the specific allergen that you're allergic to, usually environmental allergen, and then inducing immune tolerance. Some of the studies that looked at immune tolerance have indicated that usually it takes about 3 to 5 years on allergy shots where you actually induce longer lasting immune tolerance. Um, and so I think that, but that is a great question. I think every individual is a little different. So I think talking to your doctor or medical professional about whether or not it pertains to your specific case would be helpful.
Right. And are there any differences in allergy treatment between Western and Eastern medication?
Um, are you talking about like alternative therapies or?
Yeah, so like Western medicine compared to, for example, like traditional Chinese medicine.
Yeah, okay. So the question is whether or not there are differences in
How they're
treatment.
used or treated in
Yeah,
different like countries, different contexts and culture.
yeah. So, that's a great question as well with traditional Chinese medicine and alternative therapies. Unfortunately, there's not as many studies looking at these kinds of therapies. I think it's an important point, though, that certain Asian groups will use these therapies and for professional or healthcare professionals to understand how it may interplay with Western uh, allergy therapies. There are some, I guess, certain non-medication therapies that have been, tried and also explored besides allergen avoidance. Some at Stanford, Dr. Peter Huang, who's a otolaryngologist, has piloted, essentially a band which helps with using sound and vibration to move the fluid in the sinuses to help alleviate some of those symptoms, and that's not a medication either. But in terms of traditional Chinese medicine, I think that there are more that we need to know about that, more to be studied looking at that.
Mhm. Yeah, and the next question, before you talk about potential risk factors such as genetics. So currently, is genetic testing for, those risk factor a common practice? And, where do you think genetic testing falls in, the context of allergy immunotherapy in the future?
Yeah, like currently that's not really standard practice to test for um, these different types of genetic variation, but the hope is that we will in the future find that there might be biomarkers or genetic, risk factors that may pertain to specific allergy treatment. So hopefully in the future we will have, better personalized, tailored biomarkers and genetic testing to see whether or not someone would respond to certain certain allergy treatments, but we don't have that as of yet.
And another question is relating to like mixed race Asians. How has the data been on that? And in regards to allergy, so is like prevalence different? Are they more sensitive to different types of allergens? Are they typically more similar to like their Asian parents, or more so to, their other racial parent?
Yeah, and that's a great question. I think as the society is becoming more multiracial and multi-ethnic, I think there will be studies that come out regarding this. We were one of the first studies to look at multi-ethnic Asian, as I mentioned, using the Sutter Health data, and even that it was, we kind of grouped together um, patients who had one parent of a certain Asian ethnic group, and then a second parent of either a different Asian ethnic group or a different race. So we weren't able to parse out, if a child is born of someone with, of Asian descent and a non-Asian descent, what are those risk factors? There's been some work in, as I mentioned, in Australia, looking at parents or kids of parents who are either Australian born or East Asian born. And there's some suggestion that, multi ethnic kids may be at risk for certain, especially food allergy or other kinds of allergic diseases. But I think needs to be a lot more work to be done to figure out what are the actual allergic disease profiles and allergic risk profiles of these multiracial, multi-ethnic Asian groups. But hopefully in the future, we will have more data.
Okay, and another question is, when like older children develop food allergies to like food they previously had tolerated, what kind of causes this, and can it be reversed? And are there currently treatments for that?
Yeah, unfortunately, allergies are very interesting um, in the sense that, you can tolerate, let's say, like a specific food, then all of a sudden you could develop a food allergy. Let's say shellfish is one of those most common adult onset food allergies. In terms of prevalence. And so a lot is not known about what is inducing tolerance and what takes away that, tolerance or makes you allergic to that specific allergen. But it is possible that can develop a new onset allergy, even though your prior experience, you've tolerated that specific allergen. So in your specific case, definitely talk to your the medical healthcare professional in your life, but I think um, that is consistent with data that, you can develop a new onset allergy at any time of your life.
And then someone else had asked, is there any correlation into like having viral infections or any viral etiology to like onset of allergies and development of allergies?
Oh, yeah, that's a great question. There's been some work looking at asthma, especially in kids, and how certain viral infections, for instance, respiratory syncytial virus, or even certain types of rhinovirus, when kids have that early on during infancy or even early childhood, they may be at more risk of developing asthma later on. So there's some work there. There's not as much work in terms of other allergic diseases, but some suggestion in asthma.
Yeah. And then another question was, is there a relationship in having like one type of allergy to another? So for example, if does having like eczema when you were younger make you more prone to other allergies like food allergies?
Yeah, that's a really great question. In kids, there's this concept called the allergic march, which is essentially um, this idea that certain allergic diseases progress as a kid gets older. So sometimes, eczema can appear first or during early infancy, and as the kid ages, food allergy can develop, and then allergic rhinitis, and then asthma. So, we're taking a look at this in our data and seeing if there are differences in different Asian ethnic groups, but there is a concept of that. There's also this, concept of allergies kind of manifesting differently in different family members, but it can, if you have a family member with an allergy, you might be at higher risk of having an allergy as a kid.
Mhm. And kind of going off that question, how does diet, or is there any research on how diet impacts, the presentation of other allergies such as eczema? And is there any differences between different diets, like Western maybe versus Asian food, and how that works?
Yeah, so I think I mentioned in one of my earlier slides that there's been some work looking at polyunsaturated fatty acids or PUFAs and the ratio between omega-3 versus omega-6 PUFAs. And most of the work has been looking at asthma and the risk of asthma as opposed to other allergic diseases. I think in terms of diet, there's been some, thought that early on, whether or not mothers who, ingest peanut or other things, is that protective for developing other allergies, developing these allergies in kids. And there's not much data that supports that as of now, but I think a lot of work is being done looking at this, how diet can impact it.
Mhm. And then another question asked in the context of like Asians and Asian Americans, are there any overlaps between other like diseases and conditions to having allergic conditions, like comorbidities in a
I,
sense,
I see. Um, for kids or for adults?
in general?
Okay. Yeah. Well, in terms of, asthma, especially in adults, there are like comorbid conditions, for instance, obesity and diabetes or metabolic syndrome differences that have been kind of that have been associated with asthma. In terms of kids, less is known about that. We try to take a look at whether or not obesity or other, differences in metabolic profiles affected allergic disease risk, but, we haven't, we need to take a look at that more, especially in Asian ethnic groups.
And then going off of that question, in general, then is there overlap between having allergic diseases and maybe to autoimmune diseases?
So, autoimmune diseases is essentially your body, attacking yourself. Um, And, allergies are essentially there's something that's benign in the environment that your body reacts to. So there is some overlap because they're both involving your immune system, but in different ways. There's sometimes overlap in terms of diseases that are like autoinflammatory, things like that. But, I think in terms of how that plays in the Asian population, um, there's a lot that needs to be, studied.
Mhm. And then other people have asked, is there correlations between, cleanliness, personal and household hygiene, and the risk of allergies?
Yeah, that's a really great question. I'm not aware of studies specifically looking at the cleanliness of Asian households and looking at whether or not, there's a higher risk of allergic diseases in those specific households. Um, there's some data looking at how the environment, as I mentioned, affects allergic disease development. For instance, um, kids who grew up in like rural traditional farming communities, it seemed to be that those kids have less risk of allergic diseases. And so, but that's, exposure to a lot of different allergens. But, specifically about cleanliness of homes, I'm not aware of that.
And then, are there ways to kind of predict or identify whether like a child is at risk or has developed a certain allergy? And kind of how would you go about, you know, checking if a kid has specific allergies, making sure they avoid those allergies?
I guess it depends on what kind of allergic disease, we're talking about. I would say in kids, sometimes allergies, as I mentioned, manifest first as eczema or, these little itchy skin rashes, on their ankles, their wrists, their elbows, sometimes behind their knees. And sometimes kids who have eczema are at higher risk of other allergic diseases such as like food allergy and uh, such as food allergy. So I think that you know, sometimes that can be an indicator. If a child has eczema, they might be at higher risk of other allergic diseases. Um, Sometimes, as I mentioned, kids who have parents that have an allergy, um, sometimes they're at higher risk of also developing allergies. So there's been a lot of studies looking at kids with asthma, and if the mom has asthma, they're at higher risk of having asthma as well. So there are certain things that can be, looked at for a specific kid, but in terms of predicting using biomarkers or other kinds of testing, that's not, or screening, sometimes that's not really done in standard practice unless your kid already has some sort of allergic reaction. I think does that address the question, Kevin?
Yeah. Mhm. And then someone else asked, is there any evidence around early and consistent exposure to allergen in reducing allergies?
Yeah, so a lot of that work is in food allergy. So early introduction to food is encouraged and recommended um, because there are studies that found that kids, especially high-risk kids who received early introduction to foods early on during infancy had a lower risk of developing food allergy later on in life. Yeah.
And then someone else has asked, kind of in a cultural sense, how do you, kind of recommend individuals kind of navigate situations where, their parents, especially commonly, parents who have immigrated here that don't have allergies compared to kids who end up developing more allergies? How would you go about navigating that and clinically, how would you go about that?
Yeah, it's actually it's a very good question because a lot of parents are surprised, that their kids have allergies because they themselves did not experience that. And so I think um, having more education about even surrounding the fact that, even though the parent didn't have allergies, that the child can develop allergies and new onset allergies, and that's something that can happen is helpful for parents to hear. I think that, it's sometimes difficult for parents who don't have that experience to navigate the management and also treatment for, kids with food allergies. So I think it requires a lot of education, and also ideally we would have more, community education about these different factors. But it's a great question.
And kind of also building off that question in the context of migration. So to people who, kind of migrate somewhere else and develop new allergies, when they go back to their countries, right? Do the allergies go away or are still there? Kind of how have you seen that happen?
Yeah, that's actually a really great question. Like, there's really, I'm not aware of studies that have looked at that because usually they look at immigrants coming to the country, but it's really hard to follow them after they leave that host country and then emigrate back or to a different country. So I'm not sure how that would, what would happen for those specific individuals, but I think it's a great question.
And as your position as a clinician, right? So for individuals who have allergies or suffering from allergy diseases, or is caring for someone who is, right? And they don't know what is causing them. So they have like these symptoms. What do you think is the best way to kind of tackle this? Whether it's like diet, changing their environment, immunotherapy, kind of how would you recommend individuals go about that?
Yeah, I would say talk to your doctor first to see what the best strategy is for you. But I think I mentioned the big, mainstays of allergic, disease treatment, which is essentially if you can to avoid that specific allergen. And if you can't avoid that allergen for whatever reason, then you could try, medications or other kind of symptomatic treatment. And if that doesn't work, then you can also try immunotherapy or allergy shots as well, or even, in certain cases, depending on what, the severity of allergic disease, you can have, biologic treatments or other things like that. I think it really is a very individual discussion with your doctor because everybody is a little bit different in terms of what the risks and benefits, they or of treatment and other management strategies they want to use or have.
Perfect. Awesome. So I think I have touched on every question that has been asked. So I think, and we're close to wrap up time. So I think it's a good spot to wrap up. So once again, thank you so much, Dr. Arroyo, for your time. We really, really appreciate your great talk today. And thank you everyone for attending. And please look forward to our next monthly community talk. And I hope everyone has a great evening.
Right. Thank you, everybody.